Good morning, everyone. I'm Kelsie Timbie from the FUS Ultrasound Foundation, and I will be guiding the discussion today that is based on, we had 7 talks that were loaded in the on-demand section, going over these various different modalities and some of the data that we have regarding their effect on the immune response in cancer cells. So before we dive into kind of a more general discussion, I'd like to open up the floor for any questions for our speakers. That would be Dr. Allen, Ferrara, Rapasky, Koklova, Moritaitis, Price, and Guha. I think we have everyone here other than perhaps Dr. Rapasky. I believe she had a conflict. Again, this is designed to be an open, friendly discussion, so please feel free to pipe up. If you can use the raise hand function, just because we do have a number of people online right now that will help us kind of keep track of who has questions. Please, if anyone has any questions for the speakers from those talks that I mentioned, please go ahead and feel free to speak up. And if we could ask our speakers from that session, oh, there we go. Looks like everyone's popping on. To come on video, that would kind of facilitate things as well. I see Fred has a question. Go ahead. Okay, thanks. Yeah. Good morning, everyone. So the question was for Coy and Tatiana, that they I think in both of their talks, they mentioned an increase, a potential increase of interferon gamma and PD-1 expression following histotrypsy. So I think both, let's say, shockwave histotrypsy or no, interesting histotrypsy and bowling histotrypsy. So is it a common feature of all histotrypsy, and is it something that is common to all tumor types, or is it specific to, you think, to the model you studied and specific to this type of experiments?
Hi Fred, and hello everyone. This is Coy. So I'll start if that's okay. So we see interferon gamma in our histotrypsy, but we also see it in some of our other non-thermal ablation modalities that we work with. We see it in the context of irreversible electroporation as well. We don't see it as pronounced in some of the thermal modalities that we work with. Interferon gamma is interesting because PD-L1, PD-1, that signaling mechanism is downstream of interferon gamma. It's inducible by interferon gamma. And so we can see, at least in histotrypsy and with IRE, we do see these increases in interferon gamma. And in some tumor cell types, we see increased expression of PD-L1. This isn't true for all tumor types, but we do see it in the context of, for example, we see it in the context of pancreatic cancer, and in the context of breast cancer, we don't see it. And these are in mouse studies. So these are PANO2 mouse models of pancreatic cancer and 4T1 models of breast cancer. 4T1 in our hands, the 4T1 model seems to be more, I'll say, immunogenic. We seem to have more systemic immune responses in our 4T1 models, not as much in the PANO2 model. And so one of the things that we're looking into is that are these increases in checkpoints related to that less optimal systemic immune response that we see in the pancreatic model. So the applications of that would suggest that in some tumor types, this is a more dominant feature. And it could also be a reason for less stellar systemic immune responses in some models and better responses in others.
Yeah, and I completely agree that it's more tumor dependent than it is sort of non-thermal modality dependent, IRE and histotrypsy being 2 common ones. So we've seen sort of different, in different works, different reported dynamics, I would say, of interferon gamma release. So for instance, in kidney tumor model that we've done histotrypsy in, we've seen interferon gamma increase in the kidneys, not immediately after the treatment, but long time after the treatment. Whereas in the neuroblastoma study from Children's National, they saw it pretty much immediately. And Coy, I believe that's the case for some of your studies as well. So which characteristic of the tumor exactly does this depend on is a good question. I don't know if you have thoughts on what do you think it is that makes it go up either right away or later?
Yeah, we have seen similar responses. It really is temporal in terms of when it's getting upregulated. We're looking at different forms of cell death that may be related to this and how the innate immune system recognizes damps and signals. But there are it's a great unanswered question, at least in my opinion, on when is it coming on and for which types of cancer.
I actually had a question for Dr. Farrar. When you were mentioning your mechanical treatment, and this is partially from my ignorance on the various settings related to histotripsy. So do you think what you were doing was actually boiling histotripsy, or would you call it something more like a mechanical fractionation protocol?
I would call it more like a mechanical fractionation protocol. So with our system, we can generate peak negative pressures on the order of about 15 megapascals. So substantially less than, and peak positive pressure is similar, substantially less than are typically used in histotripsy at least. And in that protocol, we did make an effort not to, and we did use MR thermometry. So we did make an effort and we did monitor temperature, and we didn't see a difference in temperature in that study. So I would say that it's, it is substantially different than and so we were trying to use exactly the same instrumentation and MR monitoring methods that we would use with thermal ablation for that, in that particular model and with that particular setting. So it is substantially different, I'd say, than what people see with histotripsy.
Do we have any other questions for our speakers regarding their talk? Go ahead, Fred.
Thank you. It's a question for Dr. Guha. What can we learn from radiotherapy maybe for focus ultrasound? So it seems that the future you describe in terms of combination of radiotherapy and immunotherapy is to use subablative radiotherapy, chemoradiotherapy before an adjuvant setting of immunotherapy. Do you think the same will apply, or can we discuss if the same would apply for ultrasound? Do you think that that's the way to go, a subablative or kind of treatments?
Yeah, so that's a great question. But at the onset, I want to differentiate certain things of radiation from ultrasound. Most of the ultrasound applications which we are going through is a single shot application. So we are not doing fractionated radiation therapy over 6 weeks, right? So ultrasound is a one shot affair most of the time. Now that's interesting because, what I showed was there are two types of radiation, and like ultrasound, for radiation, everything is a different drug. So if someone is using the standard fractionation of radiation over 6 weeks, 1.8 gray over 6 weeks, the only trial which has shown success is when immunotherapy is combined after the completion of radiation therapy. So that's the Pacific study. In contrast, there was a study done in head and neck cancer where they used the standard fractionation over 6 weeks and concomitantly used immune checkpoint therapy. And then again used after completion immune checkpoint therapy. And this trial was just not only negative, probably caused more harm to the patients with immunotherapy, because clearly as radiation was activating T cells and the T cells was infiltrating the tumor, the next dose of radiation was killing them. So this is how not to do a study, okay? So now to answer your question is there a biological difference between one tumor, which is going to be resected, versus when you have a metastatic disease, when you have multiple tumors in the body. So the answer to that is that in neoadjuvant setting, the Lancet Oncology paper, which I was discussing in my talk, showed remarkably that if you use a low dose radiation, which is non-ablative, in the setting of definitive or curative surgery in lung cancer, that you get almost 26% pathologic complete response when radiotherapy was combined with immune checkpoint. But if immune checkpoint was done alone, there was 0% PCR. So the idea of focused ultrasound trying to get to the setting of, of neoadjuvant setting before surgery is a good one. The question here is, what are you doing? Are you doing ablation or are you doing non-ablation? And that is open to discussion.
So it looks like we have a question from Dr. Osada.
Yeah, I'm sorry. Good morning. Thank you for inviting me. My question or my comment is actually not about the current, topics, but for the previous discussion we had about that, PD-L1 expression by tumor cells. Because we had somewhat, interesting finding. I'm working at Duke, and at Duke we are doing mechanical HIFU, treatment in animal models, comparing with conventional thermal HIFU, and what we found interesting was like a mechanical HIFU. I agree that probably the cytokine, let's say like interferon gamma, all those stuff, actually increasing that PD-L1 expression by tumor cells. But what we found interesting was those mechanical HIFU treated tumor. If you look at that, myeloid cells, infiltrating inside this tumor, they are also having enhanced expression of PD-L1. So let's say like a macrophage or those stuff. So not only tumor cells, but also those immune cells are having that enhanced expression of PD-L1. That was kind of interesting finding we had. So that's what I wanted to comment. Thank you.
That's a great comment. We have to think about the tumor microenvironment, not only of the tumor cells, but all of those other cells that are in there. And yeah, I'm not surprised that we have found quite a bit of cell type differences in how they respond to not only interferon gamma, but other cytokines and chemokines, and then the upregulation of PD-L1 in that setting. It's something that we need to better define moving forward.
We have a question from Dr. Wu.
Hey, how's it going? It's more of a comment rather than a question, but Dr. Guha mentioned really eloquently about the Pacific trial. I think the other thing to think about when you're comparing radiation ultrasound is the mechanism of effect. Clearly we in radiation do not know the mechanism of how this is happening either, but there at least are some hypotheses that including, local inflammation, whatnot, but there's also a component of DNA damage causing neoantigens and whatnot. So when you try to use those concepts back into ultrasound, there needs to be thought about mechanisms as well, because clearly the DNA strand break is not going to be one of the components with ultrasound, but local inflammation, local damage, drug delivery, you name it, bubble interaction, non-interaction, these are all various variables that can contribute to what type of immune response you may see.
Dr. Price?
Yeah, I got a question for the histotripsy folks. So, we've seen a lot of nice data showing that with histotripsy, the vasculature is spared. Do you guys have any thoughts on how draining lymphatics fare after histotripsy? I appreciate that's going to be a function of the tumor type and the treatment regimen that you're doing, but has anyone looked at that?
So we have not looked at it specifically, and that is a great question. I think Petros has, in their recent paper, has brought it up that the mechanical disruptions could actually disrupt some of the lymphatics. But to answer your questions directly, we have not looked at it, and that's something that should be.
I'll follow on and say we haven't looked at it either. We know it's important and we know it's something we should be looking at, but we haven't had the chance yet.
Yeah, I'll only add we've done some excise treatments with large portions of the lymphatics. We've shown that they behave somewhat similar, I think, to blood vessels that are smaller vessels, but we do need more work there. We also have shown that we can actually ablate, full lymph nodes with histotripsy, and we've done some work there. And it really does depend, obviously, on the precision of our transducers. So typically, the transducers we're using for our larger bulk tumor ablation, they're not having the precision to do, single lymph node treatments, but we've done that work as well. So there is the ability to ablate the lymph nodes without targeting the actual lymphatic system. But I agree with both the others that we need more work there.
Yeah, just a comment from the thermal ablation perspective. I think, I agree that there are differences in how proteins are handled, and particularly depending on whether or not you accomplish a full ablation or a partial ablation with hyperthermia in the surroundings. But we have done PET imaging of proteins, of large proteins, where we've radio labeled an albumin and looked at how albumin delivery and clearance changes with at least with thermal ablation. And in a setting where there isn't a complete ablation, we have seen that there can be both hyperemia, as has been shown with other thermal ablation techniques surrounding the tumor, but also enhanced drainage of the protein from the tumor as well afterwards. So, and that's a technique I would recommend as being maybe an easier way than trying to look at individual lymphatics, because you can really quantify the movement of proteins away from the tumor after treatment.
But I would also submit that it's important to think about dendritic cell trafficking through the lymphatics as well. So dendritic cells with antigen versus antigen and how those are processed are going to potentially have an effect eventually on how T cells are cross-primed. So all, I think, pretty important questions to think about.
Yeah, we're at the beginning stage of looking at dendritic cell antigen presentation and uptake, but we haven't looked at the trafficking component of that yet.
Dr. Ranjan?
Yeah, I was wondering how much of inflammation is good inflammation when it comes to histotripsy or any kind of FUS modality. What I mean is sometimes in our experience, when we change the amount of tumor that gets exposed to a certain type of histotripsy, we see significant level of cytokine production, but they in turn induce tumor growth instead of working the other way. We are also seeing something similar in our canine trials. So it's a question for this group here as to what level of exposure is a good exposure, and also what is the impact of the stage of disease on employing FUS versus radiation. If the tumor is at an early stage versus more established when it has all kinds of immune cells and tumor cells in it, would the FUS exposure be more effective at an early stage of disease versus late stage? Any insights on those?
So to address the question of how much ablation is good, I guess it's been, as you know, in something as small as mice and rats and things, it's actually really hard to ablate the entire tumor without, to ablate every last cell there without affecting something on the skin. Or so most of our ablations have been partial. 50 to 80%, I would say. And we have not seen an increase enhancement of tumor growth, I don't think ever, but that's interesting. I wonder, in your experience in canine subjects, for instance, what was your finding? Like what was good working?
Well, we're still doing some of it, but at least in the B16 model, we observed that when we do like whole tumor histotripsy versus partial, in some cases, we actually see more growth post FUS exposure. We recently were doing, so we were talking about the type of tumor models and the impact it may have on tumor growth. When we reduced the amount of ablation, we saw that it was more favorable in terms of attaining a certain type of therapeutic response. So when it comes to the mice model, based on our early studies, we feel like too much of histotripsy may not be a good thing because somehow the overproduction or overinflammation that is being generated due to those treatments have a negative impact on tumor growth than positive.
Or could it also be that you are basically ablating all the good T cells and all the good players that have crawled in there, and now they're all dead and not there, I guess?
Yeah, and that is where I feel like the stage of disease is an important aspect of it. Like if you're treating an established tumor and versus an early stage tumor, there could be some of it that is coming into play. Because if you have some immune cells that have already been exposed to the antigen, they may work differently versus if you have none of it and you treat all, you create a lysate and then basically the immune cells have to go look for them at different parts of the body. In dog trials, ablation works great. It has immune effects based on the tumor type. Histotripsy, we have had mixed results and we're starting another trial soon, so we'll have more to talk on that. But at this moment, we don't have a conclusive thought on our end as to whether it really works.
Dr. Guha?
No, so you were bringing up a very important point, Ashish. So one thing from the radiation literature, which we learned very well, which is that if you have the type 1 interferon response in the tumor cell, that causes immune resistance, radio resistance, and all kind of resistance. On the contrary, if you have the type 1 response in the plasmacytoid disease or myeloid cells, you may reprogram them for cross-priming. So there is a big difference on where the inflammation is induced. Now, yes, you are bound to get some form of type 1 interferon response from the DNA damage of radiation in the tumor cell, but most of these cells usually end up dying. So therefore, that's okay. But if you have just a type 1 interferon response, that doesn't mean it's great. It's just in the context of which cell it is good.
Dr. Allen?
So I'll follow up with an expansion of both of the last two. So we have not seen any growth of tumor following histotripsy in both our mouse, pig, and veterinary patients that we've treated. But we're always trying to figure out the right balance of how much of the tumor to ablate. We are not getting full ablations. We're not trying to get full ablations since we're trying to focus on the immune response. And we're always struggling with timing, right? So do we treat and how much do we treat? And then also, do we treat and resect? Do we resect and treat what's left? So those are always things we're trying to balance in trying to optimize the immune response that we're seeing. And it's something that we're actively looking at. We and everyone here, I'm sure, is actively looking at that.
Dr. Bullock?
Hi, so I'm pondering some of the sort of continuity between these different techniques and the outcomes with the interferon gamma response. And I'm wondering to the extent to which Coy and Tatiana, even Chandran, have characterized very early innate cytokine responses as a function of the different modalities. And Coy, this is really going right into Coy's wheelhouse, so looking at inflammasome, the types of inflammasomes that are getting activated both in the tumor cells, the hematopoietic cells, and even the stromal cells that happens as a function of the sonication. And the reason I think this is important is some of the work that Kathy did previously, showing that the addition of CPGs really augmented the activity of thermal ablation in some of her models. And I'm wondering the sort of balance between type 1 interferons that Chandran was talking about and potentially IL-1 family members that come out of the inflammasome activation, to the extent to which that has been characterized in these models, whether it's tumor type dependent or is it modality dependent? And some comments on that would be quite interesting.
Tim, since you called me out by name, I'll start. Yeah, so this is something that so before I worked in focused ultrasound, I worked in pattern recognition receptors, and so I love pattern recognition receptors. It's what my lab does, and so we have looked at this quite a bit, and it really is a mixture of pattern recognition receptor signaling that gets turned on after I'll say histotripsy, but also some of the other ablation modalities we look at. The patterns, the damage associated molecular patterns that are released following treatment really do matter, and they drive those early immune response signal processes, and cell death mechanisms are really important as well. So the type of cell death being induced by the modality really does matter here, because if you have necrosis versus pyrotosis versus any of the other 20 or so cell death mechanisms in between, it really can impact the ensuing immune response. In terms of pattern recognition, we have found roles for inflammasome formation. So the cytokine of interest there, cytokines of interest, are IL-1 beta, but also IL-18, depends on the types of cells that are in the environment and which are still left after the ablation. Remember, a lot of times we're talking about with histotripsy, the cells that are remaining are the ones that are doing all the signaling. And so they're recognizing all of the PAMPs that are released, and the DAMPs that are released, the damage associated molecular patterns. We've seen a lot of signaling associated with HMGB1. We've also seen a lot of ATP associated signaling. And also we mentioned DNA, nucleic acid sensing is really important, especially STING, mechanisms associated with STING pathways. And so those are some of the pathways that we found are really important following histotripsy, and also some of the other, I'll just call them non-thermal ablation modalities. Thermal ablation, we see a different mechanism. We do see more necrosis. We see more just general damage responses, at least based on what the modalities that we've looked at. Sorry, I don't know if I answered your question or not.
Yeah, you did. So do you see that directly correlating to different levels of type 1 interferon versus IL-1?
Yeah, we do. The balance between interferon gamma, the type 1 interferon signaling, IL-1 beta, IL-18, all tend to be driven by the types of caspases that we see. So those are correlated. We get a lot of caspase 1, we have a lot of IL-1 beta. We tend to have less of an interferon response in those cases, but we still do get some type 1 interferon signaling as well with that.
Towards that, Coy, which cancer types did you observe that in?
Yeah, so this has been in our PANO2, so the mouse PANC model, and then in the 4T1 model with breast tumors as well. We have looked in other models, but we have not collected as much data to draw solid conclusions in other tumor models.
That's interesting, is in renal cancer that we've looked at the most, we do see HMGB1 similarly very transient right after, essentially, and then it's gone. But we have not at any point in time up to, from immediately after up to 8 weeks after, seen any trace of IL-1 alpha or beta or IL-18 we have not specifically looked at, but it's interesting that, yeah, there we did not see that.
It depends. So for us, it really does depend on the tumor type. Epithelial-based tumors tend to produce a lot of IL-18. Macrophage, so immune cells tend to produce a lot of IL-1 beta. It's just the mechanisms involved in how they recognize damage are a little bit different, and they tend to favor one cytokine over another. Yeah, I'm not surprised. Again, tumor type and the type of modality used to trigger that response is really interesting or really important. So I'm not surprised that in my models we see slightly different responses than others. Again, the type of cell death being induced will drive some of those mechanisms.
Hi, maybe one quick remark in this same context. Hi, I'm Jose Adema from the Radboud UMC in Nijmegen, the Netherlands. And we heard a lot about these cytokine patterns and also who is making it, and I think that's really important. But another aspect of these cytokines is, I think, their timing and the duration of their presence. And one thing, a cytokine is often meant to have a local peak, and then it can do a lot of good things like type 1 interferons. But prolonged exposure to for example, type 1 interferon is actually a very bad thing, and it makes cells very numb. So I think this timing also in the peak of your antigen release and the burst in cytokines is a very close thing to watch for optimal effects.
I actually have a question and follow up to some of the things that Dr. Ranjan brought up. So one of the things that jumped out at me when I was watching the talks was thinking about the immune cells that are present in the tumor prior to treatment. So I believe Dr. Koklova, you mentioned this, and I know the UVA team has had trouble with doing partial treatments on tumors that have like a large MDSC population prior to treatment, and how that might play into our decision as to how we go about treating it. Does it make sense for a tumor like that you go in and really hit it pretty hard and try to get a clean slate, versus a tumor where maybe you do have some beneficial T cells in there and you want to go, kind of take a step back and try not to kill off all the T cells that are in the tumor? All right, I'm going to call on Fred if he could address some of that, because I know you guys have dealt with that in the breast tumor model at UVA. Not to put you on the spot there, Fred.
We spoke. Tim would be maybe the best candidate to answer. But what happened early on the partial thermal ablation on the 41 model was that tumors seemed to be not responsive, and one of the reason identified for this absence of response, as you mentioned, Kelsie, was hypothesized to be the high immunosuppressive microenvironment, and especially the presence of MDSC. And this was bypassed by combining FUS and thermal ablation with, let's say, targeted therapy against MDSCs. So, which I think a more general question about what type of microenvironment is more amenable to respond to the FUS, and maybe the question for the speakers, if a specific type of treatment, let's say thermal ablation or histotripsy, or as Eli described, LOFU, for example, is more would be more amenable for a specific tumor microenvironment.
Dr. Bullock?
Yeah, just to sort of clarify and build on what Fred was talking about, we included gemcitabine as a known myeloablative agent to try and change the sort of the tone of the tumor at time of sonication. And as a consequence of that, we were able to demonstrate a systemic T cell dependent control of the 41 model by thermally ablative focused ultrasound. Now, to be fair, we don't know the mechanism of action at this point. We have a hypothesis that we were the gemcitabines working by ablating the granulocytic immature myeloid cells that are commonly found in the 41 model, but we have to take alternative interventions by antibody-mediated depletion of these subsets, et cetera, to really firm that down rather than gemcitabine changing some aspect of the tumor cell death that is now pro-immunogenic, for example. We're starting a clinical trial at UVA with led by Drs. Brennan and Dillon, where we're doing a window of opportunity trial with gemcitabine with thermally ablative focused ultrasound to see if that's consistent in the human context. But I mean, it's a major issue, and I think we're seeing in multiple models now that part of the response that is initiated by focused ultrasound in particular is kind of like a wound healing response. So the type of myeloid cells, the chemokines that are produced upon sonication tend to bring in the wound healing and proangiogenesis myeloid cells, which could complicate attempts to promote adaptive immunity. And so, I mean, it's kind of interesting whether all our experience to this point has been in thermal ablation, and gosh, you burn something, you get a wound healing response, shocker, right? But why that's not, if it's not happening with histotripsy, and why that is and it goes back to that innate response. As Dr. Adama was talking about, the intensity of the cytokines and the duration of the cytokines that are produced could be highly influential in the recruitment of different subsets or the differentiation of the myeloid cells. And I think we need to have a lot more optics on that. And I think there's going to be a great opportunity for imaging rather than flow cytometry to start tracing the longitudinal myeloid response as a consequence of these different sonication regimens.
Dr. Price?
Yeah, maybe just sort of a bigger picture comment that ties into this discussion, Kelsie, that you started here. I think, this is a window of opportunity for focused ultrasound to come into precision medicine. It's it's an opportunity to use some precision medicine tools to get a better understanding of what you're dealing with on a patient per patient basis before you actually go in with your treatment, because the treatment for patient A, who has the same indication as patient B, could be quite different depending on the composition of their tumor at that time point. So maybe that's a thing that the foundation should think about in terms of support going forward.
I will add that to our wish list. Thank you. Dr. Ferrara?
Yeah, just to support that idea, we've been doing single cell sequencing of a couple of different tumor types and then looking at the effect. And certainly the breast cancer model that we use was generated by our mouse biologists to look a lot like human epithelial breast cancer. And they're very critical of 4T1 as a comparison, just as not having many of the characteristics. But specifically, it's very dense in terms of cell-cell integrity and cell-cell junctions, as well as having a very dense tumor cell number. And it generates a very strong wound healing response when it's thermally ablated. We haven't yet, in that model, we haven't looked at histotripsy. But if we compare that to the other model that we've used is our KPC model, and there's the tumor cell density is pretty low. There's a lot of stroma, and the wound healing response that we see is much attenuated. So there are a lot fewer. There's a lot less IL-6. There's a lot less inflammatory cytokines in general, and we don't see nearly the level of wound healing response that we see in what we call NDL, which is an epithelial breast cancer.
All right, if we don't have any other comments, I'd like to move our discussion on to thinking about what we like to call our roadmap. So from the foundation's perspective, we'd like to know where we can best help the community as a whole. So if anyone has other ideas like what Dr. Price brought up, knowledge gaps, things we really need to think about, anything the foundation can do to help coordinate, we'd love to hear about those ideas. So kind of bigger questions, what do we need to know to move this discussion forward in the future? So I know we've done some consortium projects in the past, meaning we've taken the same tumor model and compared modalities in the same tumor model. Is there room for future projects? If so, what do we need to focus on? What are the big questions? Do we still need to think about specific tumor models? Do we need to broaden things a little bit and think cold versus hot, or get even a little bit more specific and think about immune cell populations in the tumor? If we have any comments on that, Dr. LaValle.
Thanks, and really an amazing discussion here. And I think a lot of thoughtful science. And, you know, as I've listened over time and all the work that's been done, there's a lot of complexity. So it's hard enough when you're thinking about chemotherapy and like PD-1, you have multiple modalities with different mechanisms, but I was struck by the comments that different cell lines give you different responses. So you have a tumor intrinsic factor that seems to be influencing the response, as well as the variability of the multiple modalities. And I think Tim Bullock's comments about the window of opportunity, if you really want to accelerate the treatment to patients, given, you know, I liked Kathy's comment that a lot of people don't like 4T1. I just always think of them as models, not necessarily reflective of the disease per se, but a mouse cancer model, if you will, but it has its limitations. So perhaps the best way is to look at a tumor type that you think has the most biology with it. So even with the interferon gamma response that upregulates PD-L1, do you have it inflamed? So you have to have the T cells there too. So maybe take a responsive tumor, an immunologically responsive tumor, and then do a window of opportunity study with a subset of patients, you know, really even to do 5 to 7 patients per treatment and really compare and contrast and try to get both the tumor information and the immune cell information, because it's an immune system and you need the whole thing to work together. And you might get more information about kinetics, timing, and rational combinations that way.
Dr. Zhu?
Yeah, I really enjoyed the discussion. I thought it was great. One thing occurred to me that I have been trying to follow literature, but I still get information here that I didn't read. And there's so many different, like Teresa said, there's so many different models out there, different data. I wonder if it's possible to have some sort of database and people can log in and just, you know, report their publications or their findings. So it will be easier for people to share the results in a more timely fashion. And the second thing that kind of really triggered my interest is the discussion on even for histotripsy treatment, right? We hear all these various results here because of how the treatment was delivered, not just a model, like, you know, under tumor volume, different tumor volume treatment, over treatment versus under treatment, so on. And then all timing information, right? So it seems like that when we see, you know, when we discuss different modalities, but even within the same modality, it also has a high dependence on the parameters and the treatment delivery. And they can induce very different immune response. And I feel like that probably also vary, across different models and probably worth the discussion. So, before we said focused ultrasound can be different from focused ultrasound because you have mechanical and thermal, but now make me think that histotrypsy can be different from histotrypsy because you're treating different way. So that may be another topic to look into.
Yeah, I totally agree. And just to go back to thermal ablation as well, thermal ablation can be very different depending on exactly what you do. So we have, because we work under MR and we typically try to thermally ablate instantaneously a region of a few millimeters, so more like a human treatment. I think it's very different than than just a set of very small foci that are treated in a grid pattern. So I agree that histotrypsy can be different than histotrypsy and thermal ablation can be different than thermal ablation, and the models all matter. So and maybe the way to summarize in some ways is to show examples of where people are achieving a positive response, with a model with exact parameters and just and kind of summarize the successes and maybe also the failures, but definitely the successes of what did the biology, what did the pathology, what did the immune cell profiling look like, and what were the exact parameters of the treatment that did produce a successful response. Because we definitely think that the ability to debulk tumor and combine that with a good immunotherapy protocol is going to work. There's a lot of good things. So finding a way to summarize the various sets of parameters people have used in a successful treatment might be helpful.
Dr. Wu?
Hey, thanks. So I just want to comment from a clinical side. One thing that is challenging for immunotherapy is not just the type of cancer, but specifically even within the types of cancer, who these patients are. One of the things we learned from the Pacific trial that Dr. Guha had mentioned is that unlike other cancers, metastatic cancers with immunotherapy, where you have to have a baseline expression of X amount of PD-1 or whatever, the Pacific trial taught us that with radiation, whatever you have at initial biopsy, it doesn't matter because things change. So I think it's not just the caution of choosing the cell line or the cancer model, but it's also being cognizant of what is the baseline of this tumor that is being tested across the board and what's the applicability. Second comment I wanted to add is, from the foundation standpoint and all the ultrasound experts, I can clearly understand the excitement of using focused ultrasound and immunotherapy to get the win. But the question is really that win the easiest way to make a clinical impact, or is it just an incremental advancement in the deadly cancer? So what I'm trying to say is that, maybe the right answer is if we know on the clinical side and just spitballing, radiation can induce cancers, and that's already proven in the Pacific trial over and over again. What if we just said on the adjuvant point, we wanted to use a immune stimulation that's non-radioactive, non-cancer inducing, like focused ultrasound to improve the therapy? So what if we had a model where it was radiation chemo that's already proven, and the subsequent immunotherapy before treatment, you add focused ultrasound? I feel like from a clinical standpoint, that's still a win because anything that you get ultrasound into will be a win.
Dr. Allen?
First one, I started talking while my mute was on. So just following up on that, yeah, we've always viewed the focal ablation modalities as something that would need to be done in combination with other therapeutic approaches. And so I think to go back to Dr. Price's comments, I think in terms of how the foundation can help, it really is. I think all of the comments, all of the discussion here is really emphasized that this is going to be a personalized approach for patients. And where the foundation can help, we really need to define the biomarkers. We really need to define what each individual patient will benefit, how this can benefit each individual patient and their tumor type and their immune status.
All right. Do we have any other general comments, ideas, thoughts? Dr. O'Donnell-Tormey.
Yes, I just I have maybe it's a naive question, but in terms of trying to move this effectively into the clinic, is there enough data that from all of the models that are being tested and all of the different types of focused ultrasound that there are, can there be kind of a consensus that something looks good, that it's working in these models, that we could then understand, could we just add that to an immunotherapy treatment where we know in cancers where immunotherapy, where PD-1, anti-PD-1s are not working? So, you know, could we pick pancreatic, or could we pick prostate, or do you pick glioblastoma? And is there enough known right now, after all these years of modeling and understanding this and measuring different responses of focused ultrasound, to just ask a question, can we just do this, add it to an ongoing clinical trial as a new combination, and do the really deep correlative analysis on a single cell basis, and even, you know, even visually, what is happening? And I don't know what the sequence, and I understand we don't know sequencing, but could we put focused ultrasound first, get samples, understand what's going on, add the PD-1 in a clinical trial in a cancer where we know it doesn't work, to see if it increases the responsiveness to a checkpoint blockade? I mean, is that the really next step that needs to happen? But do we have enough information to, there's so many options and so many potential combinations. Can we get a collective consensus of something that you can move into, ask a simple question like that, and be able to do the in-depth analysis in, as Teresa said, in a very small number of patients, to really get a in patients what's really happening in a certain tumor type where we know therapy doesn't work? Are we there yet?
So I'll just jump in on this one. I think for a phase 1 study for safety, and you'll get data for secondary correlate and whatnot, you know, it's all about the risk to the patient, right? So, you know, if you choose a cancer where immunotherapy is part of standard of care, say melanoma, right? And you wanted to add, say, topical focused ultrasound that's even thermal, or, you know, whatever you want, that's not going to be a risk, that barrier of entry will be low, and you can have a window of opportunity and whatnot. And I think the tumor selection and what you want to do, especially like skin or melanoma, would be great, because if you wanted to, say, shave a little more and get tissue for sequencing during the process, you have the opportunity and easy access to that with minimal morbidity or risk. So I think there are certain sites who are more amenable to it. There's other sites like brain will be much more challenging, but I think this is definitely, you know, worth exploring.
Right, Dr. Ferrara.
Yeah, and just to comment on the pancreatic side, at least at our site, the request or the requirement was that we establish safety of focused ultrasound first, and followed by standard of care chemo, and that's what's ongoing now, with certainly with the goal of then, once that's established, adding immunotherapy to the protocol.
I think this will be we'll just have time for one more comment before we go to the break. So go ahead, Dr. Price.
I'll be really quick. So Jill, just to your comment before, we are, although not exactly the way you stated it, pretty much embarking on that same pathway right now at UVA. So I think this afternoon, Patrick Dillon will talk about Breast 54, a new clinical trial starting at UVA that combines gemcitabine with focused ultrasound. And that is based off of a preclinical study we completed last year. So we will be doing the types of analyses you're talking about on those patients that will hopefully, you know, get us going in that direction.
All right, well, with that, we will wrap up today's discussion. Thank you to our speakers as well as our participants.